Afternoon and welcome to the afternoon session. I just give you an introduction why I chose this subject because I'm sure every one of you got some remarks about it. So I got a WhatsApp from one of my vascular colleagues, Dr. Martin. He sent me a few pictures. He said, bro, this patient needs help, needs very tight control. He's poorly controlled. We need to save him. Save his limb from amputation. So this is the vascular. I'm sure you get the same report when you refer a patient to a nephrologist. We have Basil is here, refers the patient back to you for better control. Have you done this before? You will take care of it? Or a cardiologist, maybe Dr. Taysir was here. You send the patient, they send the patient back, he needs a tighter control. So everybody is talking about a better control, a tighter control, but I don't know who is right. Everybody's looking at it from his point of view, so we'll see. In real life, we face this in multiple levels. Those who have only clinics, you see this patient as outpatients. So you look at the HbA1c of the level, blood sugar chart of the patient, maybe now CGM results. You can look at that and judge how tight you need your patient to be. In hospital patients, you have either referrals from critically ill patient, an ICU patient, or from non-critically ill patient from the wards, from other subspecialties. So you'll face this question everywhere. Whether you are in your OPD, everybody will ask you to have tight control, or whether you are in a hospital, they are always not happy with what you do. This is the same patient. I mean, once he was admitted, sorry for the bad quality of the sugar. So again, this just numbers, looks high numbers with low numbers. How significant are these for a surgeon, for a vascular surgeon? They look bad. For others who work with insulin pumps, maybe we'll look at it differently. They look at the time and range, the variability of glucose, so many variables but everybody agrees it looks bad for somebody who has complication and inpatient. So what is the target for such patient who is admitted in the hospital? You have been pressed by your surgeon colleague, he needs a tight control. Do we have any evidence based? Do you have any guidelines? We're going to look at that. So regarding this patient has multiple comorbidities, and now he has a diabetic foot abscess, abscess with cellulitis, and there is a demand to tightly control this patient. So how would you, in this patient, and assume he's in the hospital, he was kept on sliding scale actually. That's variability, part of that variability, you see the numbers are high and low because they just put the patient on sliding scale, which can have this variability in your patient. So just for us, so how many of you will keep this patient blood glucose target from 4 to 7, tightly controlled? Majority, nobody? What about the second, 6 to 10? You'll keep it at around 6 to 10? The vascular surgeon will not be happy with him. He will call you back for tighter control. He will say this is not controlled. What about keeping a more liberal, 6 to 14? 6 to 14 millimole. Keep it liberal. He's comorbid with so many complications. Risk of hypoglycemia is hazardous. If you can cause hypoglycemia, can cause problems with this. The vascular surgeon wanted the first one. He wants the numbers to be very tightly controlled, around from 4 to 7 millimole per liter. You have to be ready how to answer these people with evidence-based and with guidelines, as you will see. So, real life, before guidelines and evidence-based medicine, patients are different. Different parameters, different risk assessment of this patient, different comorbidities. So you have patients with low risk, moderate, severely, high risk patients. You cannot have the one shoes that fits all. And the magical number that this is tight for this patient, but this is not tight. This is too much for another patient. So again, we'll talk about individualization of therapy. So there is no magical answer. We're going to find few answers according to the guidelines, but a number that fits everybody and doesn't make sense at all. So each patient should have his own target blood glucose. Just an introduction. Why diabetes? Diabetes is a common disease in Bahrain. The latest IDF Atlas said it's 11%. I think it's more, 14 to 15%. This is for the outpatient. So you are likely to face a diabetic patient, whether you are a GP, whether you are an internist. What about inpatient? at any time, maybe 1/3 of your inpatients admitted for any other reason than diabetes, they are diabetic. Ortho patient, cardiac patient, nephro patients. So you are likely to face such patients in the patient care in the hospital, and likely because of the increased prevalence of diabetes to see this patient in your outpatient practice, whatever you are doing, primary care, secondary care, and internal medicine. So be ready for this challenge. An interesting question. What is the culprit? Is it hyperglycemia or diabetes? Actually, it is both. Whether you are non-diabetic or we know that from critical care studies, well-designed studies, the non-sugar and the other studies, that even just hyperglycemia is associated with poor outcome, whether you are a diabetic or not. We mentioned this. So being diabetic or non-diabetic, hyperglycemia definitely has adverse outcome in morbidity and on mortality as well. Okay, this is to please my vascular surgeon, make him happy and to argue with him. He looks at this as if it's only diabetes. He's calling me, he needs tight control. These patients are cardiovascular patients. They have so many risk factors. The lipids, the high blood pressure, the obesity, the other causes, but what he looks at is looking at the diabetes control. He wants this to be done. To be fair, if you'll handle this patient as diabetic, you have to address all the risk factors as a diabetic patient, whether blood pressure, lipids, or other. So definitely you have to handle this. Just look at these numbers and facts. They're scary, really scary. Sometimes we underlook these things. So for my vascular colleague, he knows that. He said this is the commonest, the diabetes mellitus is the commonest cause of non-traumatic lower extremity amputation. Half of the cases of amputation after trauma, it's diabetes. Diabetic patients have 10 times more risk of having amputation, lifetime risk of having. Once a diabetic patient have 25% lifetime developing foot ulcers and complications. Once you develop a diabetic foot ulcer, it's not the end of the story. You have almost 30% chance of developing another ulcer within a year. 55% of those with amputation, they will have amputation of the contralateral leg 2 to 3 years from the initial amputation. 50% of patients with amputation will die within 5 years of amputation. So it's a serious problem, has to be taken care of seriously. This is well known, and that diabetes impairs wound healing in different stages, the 4 stages of wound healing from the beginning, from the homeostasis, inflammation, migration, and the remodeling through different mechanisms, the hyperglycemia itself, through inflammation, micro and macroangiopathy with dysfunction, autonomic and sensory neuropathy. So there is no doubt that diabetes interferes with wound healing through different mechanisms, and actually in all the stages of wound healing. Okay, now before we go to the guidelines, what evidence that we have to deal with such patients, especially our patient, a patient with high cardiovascular risk patient who has a diabetic foot ulcer, which is common in real practice. Unfortunately, the evidence that we have, the strong evidence that we have is just cause and result. That we know that poor glycemia is associated with increased morbidity and mortality. Both in critically ill, non-critically ill, we have some good design studies in critically ill patient and non-critically ill patient that you're talking about hospital setting. Strong evidence-based medicine comes also from some cardiac studies, the cabbage, the Digami studies, which was well designed and well randomized. So maybe you can talk about that later. So what about our landmark studies, our diabetic landmark studies, the UKPDS, the Accord, the Advance? Would they sort the problems? We know that in these studies, they looked at tight glycemic control, intensive glycemic control, as a marker for reduction of microvascular complication, including neuropathy, and it succeeded to do that by 25%. But on the other hand, too tight control, HbA1c of 6.5 or less, was associated with increased risk of hypoglycemia and even mortality. So you are between two things: hypoglycemia, mortality, and poor outcome because of the loose control. So where should we stand and what should we do? This is just a glance at the UKPDS, our landmark diabetic study, which clearly shows that if you in the intensive arm of the group, intensively controlled HbA1c to 7 to 7.5, there was significant reduction, 19% in all diabetes-related complications, and 25% in microvascular complication. What about macrovascular complication? MI, strokes, peripheral vascular disease, like in our patient. There was some reduction in MI, non-fatal MI, 16% reduction, but that was not statistically significant. So you have some benefit which was not proven statistically. What about amputation and lower limb peripheral vascular disease? Yes, there was some benefit in the UKPDS, 35% reduction in risk of amputation, again, statistically non-significant. So you can always question this. Unfortunately, which is weird, somebody can help understand, there was increase in non-fatal strokes by 11% in those who have been tightly controlled. You expect that to have a good outcome, but there was increase in non-fatal stroke in such patient. Maybe you can talk about this as well. So what should we do? In this presentation, we lack evidence-based medicine. We lack strong evidence. My next presentation, you have a lot of evidence. You don't know what to do with. Now we are facing very observational, small meta-analyses, only the randomized control trials that you will find in such subject in the ICU setting, and even in the CCU, cardiac setting, with specific populations, critically ill patient post-CABG. But what about the regular patient that we see? A pneumonia patient who is admitted to the ward, a patient with diabetic foot with cellulitis, no randomized control trials. The best thing that I could find, before I show you the evidence, this is one of the latest guidelines, global vascular guideline on the management of chronic limb-threatening ischemia. This was published in 2019. Again, I hope it's poor quality. I'm again sorry. It says, and they're playing with the words. I'll just read for you. So they said, optimize blood glucose control for wound healing. They are just saying, optimize. What do you mean by optimize? How should I optimize? How tight should I go? How liberal should I say? They say this is a strong evidence recommendation. But when you go to the other hand, you see the level of evidence, they say it is low evidence. So you have a strong recommendation with low evidence medicine. So you have a gap here. We know that improving glycemia can improve the outcome, but we have to prove it. With randomized controlled trials, we lack that. The best thing which was there in literature, what I could find, published in 2020, was a meta-analysis of around 4,629 studies with inclusion-exclusion criteria that ended up with 47 studies included in this meta-analysis. And not going into this study, everybody wants to know what they found. They found the following, that the higher the HbA1c, the worse the outcome. We agree. The lower the HbA1c, the better the outcome. Yes, they tried statistically to find the sweet spot. Poor quality, but you will find between these two, the sweet spot, but HbA1c was between 7 to 8%. Optimal treatment. This is statistical, but this is the best that we can see. The second graph shows that in between that two diamonds, there was a sweet point. HbA1c from 7 to 8, those patients did better than the other patients. So from this meta-analysis, we know that keeping the HbA1c from 7 to 8 is the most reasonable thing to do with such patients. What about the guidelines? Okay, I'm not going to go through this. Again, we talked about this. This is the latest ADA, American Diabetic Association guidelines. I'm happy to see this. Now we are not talking, now they are individualizing the HbA1c targets. There is nothing that fits every patient. And this makes sense because it marks the real life meta-analysis that we saw. And usually it's, whenever the real life evidence matches the guideline, it means that you are on track. So it's very clear. So if you can see, it's not clear as well. So I can read for you. Maybe this. Can you see the marker? Might be in bad. So you have different factors. You have an HbA1c of 7 in the middle. You have modifiable factors and non-modifiable factors. You have to look at the patient individually. Look at the patient. Does this patient, there is risk of hypoglycemia? The duration of diabetes, the life expectancy of this patient, the important comorbidities, established cardiovascular disease, these are all non-modifiable risk factors which will make you lean toward a loser HbA1c, which according to the guidelines from 7 to 7.5, and even up to 8% those with comorbidities, with very high risk, short life expectancy, long duration of diabetes, multiple comorbidities with vascular complications. So latest guidelines say you can lose as up to 8%. You don't need to go as low as 6.5 or 6% in this subgroup of patients. And these targets are the same for the ACE and the American Association of Clinical Endocrinologists. So again, this is to emphasize, so HbA1c, each patient depends on these variables. I mean, you can look at that as well. You can see some patient modifiable variables. The patient preference. Patient thinks his work does not suit a very tight control. He's shift worker. He's a driver. He cannot afford hypoglycemia. So you think, no, I cannot be tightly controlled. This is patient preference. Or somebody who does not, somebody who's an elderly at home without support for hypoglycemia. You don't need to go for HbA1c less than 7 or tighter. These are factors that patient-centered, and you have to design your target based on your patient comorbidities, patient preference, and patient situation and support at the supporting system for the patient. This is the conclusion. So what should we do? HbA1c target should be individualized, as we said. Less than 7% for those with short duration of diabetes, low risk patient, no comorbidities, 7 to 7.5% with mild comorbidities, and less than 8% with established cardiovascular disease and long life expectancy. What about inpatient critically or non-critically? Keeping a modest 6 to 10 millimole per liter is reasonable for this patient. What about the outpatient setting? The same. The criteria that we apply for inpatient is the same. If your patient is very high risk with long-standing diabetes, comorbidities, elderly, you have to lose the HbA1c target that suits him, which is around 7 to 8%, which is more than enough. Maybe now you have the CGM data and which can, or the patient, some apps also can calculate the average blood glucose, or you can look at the log of your patient. Having an average blood glucose, the HbA1c from 7 to 8, if you change that to an average blood glucose, that will correspond to 8 to 10 millimoles per liter. That's a random blood sugar. That should be sure more than enough for this patient. So you don't need to go more than that according to the latest evidence-based medicine. Again, if your patient is a moderate risk to high risk patient, those with low risk patient, still you can go to a lower target and even to normal targets. I finished early, but I will leave the floor for discussion because I know this is an interesting subject for those who work with people in hospital. They know what I mean. A lot of referrals, a lot of problems with such patients. Thank you.